Okie doke. This is the very last lecture series in all of your med-surg stuff, so that's kind of fun. So this is chapter 63 and 64 in your book. I'll break it down into two separate videos. Shouldn't be too hard, it's pretty straightforward. Focus on the stuff that I'm going to talk about. There's some obscure stuff with eyes and ears, but we're just going to focus on the main things that you're probably going to see in practice and that what you're going to need to know as a nurse. So let's get started and talk about some of the vision stuff first. The first thing I want you to be aware of is these words. This is the Snellen chart. The Snellen chart was developed a long time ago, like archaic, like I think back by Dr. Snellen, I think back in like the 1920s. And I'm sure you've seen this, I'm sure you're familiar with it. The way that this works is you put it on a wall that is 20 feet away, put a mark, have your patient stand there, and if they've got 20/20 vision, they should be able to read the line that is at the 20-foot mark. They should be able to read that clearly with both one, do it on the right eye and do it on the left eye. People that can't, like for example, somebody that has 20/200 vision, somebody that has perfect vision, 20/20 vision, could stand 200 feet back when the person with 20/200 vision can stand 200 feet in front of them, and they would have the same vision at the same visual acuity. So this is pretty significant. And then there's some other people that obviously have better than 20/20 vision. So like your pilots and stuff have to have at least 20/20 vision, not corrected. Although some people now, some pilots can have it corrected with LASIK eye surgery. This is pretty common, probably a lot of you have had that. LASIK eye surgery now is replacing glasses and cataracts. So people that have less than 20/20 vision will get fitted for glasses or contacts to correct their vision to get down to 20/20. But now we have this procedure. It's been out for probably 20, maybe 30 years now, this LASIK surgery. What they do in LASIK surgery is they open up the top of the cornea and just sort of slide it back. And then they use a laser to reshape the cornea, and then they put the lid back on, and that's it. That's all they do. It takes like 2 seconds to do. It's permanent fix. Then the person doesn't have to wear glasses or contacts anymore. And now they're even doing it so that they can fix both nearsighted and farsighted vision with LASIK surgery. And nearsighted vision means that you can't see things far away, and farsighted vision means you can't see it close up. And it's not, the language is not based on what you can see in the distance. It's based on where the image projects on the back of the retina, where the brain actually is transmitting the image. So when you hear that near and farsighted, most people have nearsighted vision. They can't see things that are really far away, and so they wear corrective lenses. But as people age, it's something called presbyopia, and then all of a sudden they have their ability to accommodate, the lens's ability to accommodate, they lose that ability, and that it's called presbyopia, and they can't see things close up. And then because that focus, it goes too far on the back of the retina. And I'll show you about that a little bit. The other thing that's pretty common is just blindness. People who have blindness for a variety of reasons. Some people are just born with blindness. Sometimes cataracts can cause blindness. We're going to talk about that in a second. Your diabetic retinopathies can lead to blindness. That's why we're so worried about our diabetic patients and keeping them healthy. The other thing, this image up here is people who have color blindness. So somebody who's colorblind would not be able to read these numbers in here, like 12 and 71 and 6 and 42. This is an 8 because they're colorblind. Not as common, and typically people who are colorblind, they've got problems with the color capacity in their eyes, as opposed to the optic nerve sending vision images back to the brain. So those are just some other things, just sort of an overview, not hugely important, but as a nurse you kind of need to know what that is. Okay, so let's talk a little bit about vision. This pathway is important to talk about. Let me kind of see if I can make that a little bit bigger for you guys. Okay, yeah, so I wanted to talk about this. I want you to know these pathways here. Okay, so remember when we were talking about neurosciences, and that sometimes when a patient has a stroke, they can have something called hemianopsia, meaning half of your, like the patient who has that kind of stroke can see half of their visual fields. This is why. So if somebody, let's say that somebody has a stroke in this portion of their brain, well, you can see that these optic nerves run from the back of the visual cortex back here. They run on each side here. They cross over at the optic chiasm. This is right here in like cranial nerve number 3. So when your brain herniates, it herniates down on here, which is why you can get blown pupils. Remember we talked about that in neuroscience? But you can see here, so if the stroke is occurring here, and you see where this pathway goes, and it goes to the medial side of the left eye, but the lateral side of the right eye. So if the damage is here, you're going to have problems here and here. So that explains why some of your stroke patients have that hemianopsia problem going on. So this is important. So you're getting information from your left visual field and your right visual field. Both eyes are receiving this information and they're starting to process it. It goes down through the nerves, crosses over at the optic chiasm, comes back here, and then back at the very back of the brain, then in the occipital lobe, if you remember this from neuro, in the occipital part of the brain, this is where the interpretation of what's actually been visualized is occurring. So there are some different things that can cause damage in this pathway. Specifically up here in the eyes, because you've got a lot of arteries, you've got an optic nerve that's going in there, you've got your occipital arteries, and things like hypertension can cause problems and blindness, diabetic retinopathies can cause blindness, stroke, like I just said, can cause problems, age-related disorders like cataract and things, tumors growing in here, so there's a lot of reasons why somebody can have vision problems. Another common thing is like our veterans and people coming back from war-related areas, because they can get a lot of trauma and damage, shrapnel in their eyes. This is why anytime your patient is doing anything around machinery, fireworks, any kind of explosives, they need to wear protective eye gear to protect their eyes from damage. So I want you to kind of study that. There are some age-related vision changes I want you to talk about. The presbyopia I already talked about. That's the word for presby. Presby is the word meaning old, and opia is the word meaning eyes, old eyes. So that's when you see, like all of us old people who need reading glasses so you can see things up close, because you lose that ability to accommodate. Also, as your patients age, the pupil size is going to start decreasing. The accommodation slows, meaning it's going to take a lot longer for the person to be able to accommodate what they're looking at. And then the lens will lose its transparency, and this will start showing up if your patient has cataracts. And so I'm going to show you, we're going to talk, I think, first about retinal disorders. So the retinal disorders, you will hear this called either retinal degeneration or macular degeneration. Those two words are kind of used interchangeably. I'm going to show you a little picture of that, what that looks like in a second. But it is fairly common as a person ages to have a retinal disorder, and there's a couple different kinds. You can have wet or dry retinal degeneration, retinal detachment, a couple different things going on with the retina. It is not that uncommon. ARMD stands for age-related macular degeneration, and this is just a breakdown of the retina. Most of the time it starts out as a dry degeneration, and that is just a destruction of the tissue, but it can progress to wet degeneration, and that's where the vessels in the eye are actually starting to leak. Most of the time, the retinal problems don't cause total blindness, but they do absolutely cause some vision loss and vision changes. Oftentimes, it's only the central vision that is lost in some of the retinal problems, and I've got some examples I'm going to show you. But it does usually render the vision bad enough that the patient sometimes has trouble with activities of daily living. Safety becomes an issue. Driving absolutely is out of the question most of the time. It increases fall risk because they don't have as good of vision, and it just reduces overall lifestyle satisfaction because you can't watch TV and some other things like that. So this is something, let me scroll this up, back it up a little bit. You should be familiar with this. This is the eye. This is what we're going to be talking about just for the next few minutes. Is this back here is the retina. So if you'll remember from your anatomy, you've got your pupil up here. That's the part that pupils equal round or reactive to light. The pupil is the one that's innervated by the cranial nerve number 3. And then this is the outside is the cornea. The cornea is very sensitive. There's not a lot of blood flow. There's zero blood flow in the eye itself up in here. The cornea can get scratched easily. People can get a little piece of sand in their eye or something and they scratch it, which is why you want to always tell your patients, don't scratch your eye, just flush it out. Get some saline or some eye drops and flush out if you have a piece of sand or something in there. Don't ever rub it because it'll scratch your cornea. Sometimes girls will burn it like with a curling iron or something like that. It hurts really bad. It's very, very sensitive. Here's the good news, it also repairs itself very quickly. It changes over cells very quickly and heals very quickly, but at the time is very painful. And this is the lens that I was talking about. The lens is responsible for accommodating, and it will adjust this way or this way based on what it's trying to look at. So especially as a younger person, you can see in the distance 20/20, and then you can read a book here all unassisted. When a person ages and they start losing this ability to accommodate, that's when they start needing reading glasses, they start holding the book further away because the lens starts getting a little thick and can't accommodate. So when we're talking about the retina, also in here, this is all fluid. This is the vitreous humor. Now I want you to notice this is the optic disc and this is the macula. I'm going to show you some pictures of what that looks like, so make sure you're kind of getting a vision of where this is. And then this is where the optic nerve comes in. This goes back to the visual cortex in the back of the brain. That's where the interpretation of sight is actually occurring. So keep those things in mind. This is what it looks like. Now I'm sure when you guys, I'm sure you've all had an eye exam at some point. And you know when the doctor gets really close to your face and looks into your eye with an ophthalmoscope, this is what he or she is looking at. Now remember what I just showed you, where the optic disc is and then where the macula is? And so then the artery, not the artery, the nerve, the optic nerve is going to come in right about here. So this is the optic disc. This is the macula and fovea, just kind of focus on macula. And then you've got a bunch of arteries and veins. This is a nice, healthy looking inside of the eye. And all this stuff in here is the vitreous humor. Now look what happens in macular degeneration, macular retinal degeneration. Very common, especially as a person ages. It's one of the most common eye disorders that you're going to have. And what happens is when the little central portion of the retina known as the macula, like I showed you, it's just starting to deteriorate. It's getting old and just kind of falling apart. And so then what happens is like the ability to sense light at the back of the eye, it's starting to just get destroyed. So this is a cross section. Let me make this bigger so you can see it. Right there, that's better. You guys see that better? Okay, so this is I guess it's still kind of blurry, but you get the point. So this is what the normal macula looks like. You've got nice, healthy, intact tissue, and this is the normal visual field. Well, now you can see that this tissue is starting to is just falling apart. It's destroyed. This is dry retinal degeneration. And this is the vision changes you get. They start getting spots or floaties in their vision because parts of it are just going away, but other parts are still intact, so you're going to get this kind of visual changes, which is very annoying if you're the person that has it. And it also, as a nurse, presents some safety issues. This is what retinal degeneration looks like also on that same ophthalmoscope. So you can see here you've got the optic disc. The optic nerve will come in right about here, and now look at what's happening over here to the retina. You've got some destruction going on, and it just does not look as solid and pretty round circle like in the healthy tissue. This is starting to have retinal, aka macular degeneration. So how do you know your patient is starting to have this? Well, one thing we like our patients to have at least an annual eye exam, especially as they age, to start monitoring this kind of stuff. It does tend to run in families a little bit, so if you've got somebody in the family that has retinal degeneration, even more important to get annual eye exams. These are some signs and symptoms that are going to show up in your patient who is starting to have retinal macular degeneration. They're going to have, their vision is going to start changing, loss of vision. It's going to be harder to see at night because it's called night blindness. Tunnel vision is when somebody starts, they can see like this, like if you put your hands like this, you can see it, but they can't really see outside. You can do the rest of that. So then let me show you, this is another example, kind of more retinal damage. This is obviously a little bit bigger. Right up in here, you've got a little bit of wet damage going on. You can see like the leaking vessels up here. Now here's the discouraging part about somebody who has macular degeneration. There's no cure for it. So that's discouraging. So what we do is we try to prevent it. So how do you prevent somebody from having macular degeneration? One, get a good family history because it does tend to run in families. The next thing that you can do is increase the diet, the things in the patient's diet. Let me slide this down a little bit, it's too big. Vitamins A and E are really important for eye health. Lutein is important, and there's a lot of over-the-counter medications. Patients can just get this in their vitamin and herb aisle, or getting lutein in the diet. The antioxidants are really important. The omega-3 fatty acids, this is why we tell people to have fish and salmon at least once a week. Foods that are high in zinc. There are some things like for your patients who have wet degeneration, sometimes they can do laser therapies on that to try to get some of those vessels to stop leaking. But unfortunately, there's not really a cure. The other thing that can happen with the retina is the whole entire thing can detach. And you can see here what's happening is like this part of the retina, and remember from that first anatomy slide I showed you, the retina is supposed to be out here. Well, what's happening is this part detached from here, and now it's sliding down here. The whole thing is completely detached. In a retinal detachment situation, typically it comes on very quickly, and something usually brings it on. It can be sometimes hypertension or trauma, like if you hit your head. Something, usually it's much more sudden. Macular degeneration, wet or dry macular degeneration is usually a slower insidious onset, whereas retinal detachment comes on a lot quicker, and you can see like the complete shattering of an eye. But see how it's almost like a curtain, almost like a black curtain is going over the person's vision. So those are the two ways you can figure out if it's a retinal detachment versus retinal degeneration, is the suddenness and how this curtain kind of comes down where the retina is actually detaching. Sometimes if it's not as significant, you'll get these like little light flashes or little floaters in the eye. The good thing about retinal detachment is that that can be repaired. They can put that back on surgically, and this one can be fixed, unlike degeneration. So so that's it with the retinal stuff. Now let's talk a little bit about glaucoma. So the situation with glaucoma is really more of a pressure inside the eye, whereas retinal degeneration is a problem with the retina in the back of the eye. Glaucoma is a buildup of pressure inside the eye. So this is what the normal eye should look like. And in a patient that has glaucoma, you have all of this aqueous fluid, this vitreous aqueous fluid that's in the eyeball. Well, what you also have in the eye is you have a trabecular mesh in here. It's right on the side. So what happens is you've got this constant moving and flowing of fluid, aqueous fluid, in and out of the eye. And I want you to kind of think of this as like a kitchen sink. So think of the fluid in your eye as the water coming out of the faucet, and your eye is the sink, and then this trabecular meshwork in here is the drain. And you, like in your tear ducts and stuff that drain down here. So you constantly have this moving. Your eyes are very, should be, if you're not dehydrated, moist, and it, you know, it keeps them moist. You've got a lot of fluid in the vitreous part of the eye. And so this trabecular meshwork in here is the drain. What happens in glaucoma and there's two kinds. What I'm going to tell you about this open, you've got two kinds. You've got open angle glaucoma, which is the most common, and closed angle or angled closure. Those two words get flipped around, but it means the same thing. Kinds of glaucoma. Well, the open angle glaucoma, this is what I'm talking about. This is the most common kind of glaucoma. Lots of people don't even know they have glaucoma. Because the pressure builds up so slowly, they don't even recognize that it's happening. But what happens is right here in the drainage system, the drain is starting to get clogged up. You got some hairballs in there, you got some food down in there, and the water is just not running down like it should be. You got to clean the drain, basically is what's happening. Well, you know how, like, if you have a drain at home that's starting to get kind of clogged up, you don't really notice it until your whole sink is like getting filled up, and you're like, oh gosh, and that, I gotta get something done about that. I gotta, throw some drain out down in there or plunge it or something like that. That's what's happening in open angle glaucoma. So you've got this trabecular meshwork here, and it just needs to be cleaned out. So with open angle glaucoma, it usually develops slowly. It's not painful. The problem is they can start having some vision changes because the pressure now is starting to put pressure back here on this optic nerve. So if that pressure is sitting on there long enough, then the patient's going to start having some vision problems. It's going to start causing some edema of the cornea up in here. So it's going to start getting some swelling up in the cornea. The nerve fibers are going to start getting atrophying. And then you can start having some, oops, I made that too big, sorry. Some degeneration of the optic nerve. So that is open angle, that's the most common. There is another kind that's called closed angle. That's actually much more dangerous, because closed angle glaucoma is almost like somebody just put the stopper in the sink. And see, in open angle, it can come out here and then slowly drain through this trabecular mesh that's sort of clogged up. But in closed angle, this thing is just shut, and the water, the fluid that's in there can't get out at all. This is it's more rare, but much more serious situation because the pressure builds up so quickly. So what do we do about it? Okay, so the first thing that they do is you get a good assessment. So your patient comes in, they're starting to say that I'm having some gradual loss of peripheral vision. And the way that you can test this is, here, I'll stand over here. So you take your hands and you go like this, have your patient stare straight in front of you, and ask them to tell you when they can see your hand wiggling. And they should be able to see it like right about here, but sometimes people that have glaucoma, they have to, they're way out here before they can see it. So that's one way that you can assess for it. If they start having headaches, nausea, redness, their eyes could be getting red because it's basically high blood pressure in the eyeball. That's exactly what glaucoma is pressure in the eyeball. The first thing that they usually do is drops. There's a ton of drops on the market that are actually pretty good for glaucoma, and that's first line therapy. So a lot of times the drops, we try them on drops. That's first line. Then when those don't work, then we can sometimes go in and do surgery on the patient. Sometimes they can do laser therapy, and the latest thing, and I don't think this is in your textbook, is there is some studies that are indicating that medical marijuana is effective in reducing intraocular pressure for patients who have glaucoma. And so the thing that we want to do in all of our patients that have glaucoma is prevent damage to that optic nerve, because as soon as we get damage to that optic nerve, vision is going to be permanently affected. So your whole goal is to reduce pressure in order to prevent damage to that optic nerve. Okay, I want to show you something. I want to show you a little bit about cataracts.
Natural lens inside the eye just loses its clarity over time. And as it loses its clarity, the vision deteriorates.
Dr. Richard Gans is an ophthalmologist at the Cleveland Clinic and an expert on cataracts.
They see more troubles with glare. Headlights coming towards them at night are difficult. They see halos around lights. They feel like they need more light to see things because their contrast sensitivity diminishes and their color perception changes as well.
Look up, sir. And look down.
Though they can develop at any age, it's mostly an issue for the older population.
We live long enough, everybody gets a cataract sooner or later. There can be some situations where it's hereditary. There are some infants that are born with cataracts because of infections or other problems, some metabolic diseases. Diabetes, unfortunately, makes cataracts develop sooner in life than it might otherwise. So there are a variety of different factors.
Thankfully, these days it's a pretty easy fix.
Fortunately, we have a wonderful technique that allows us to remove cataracts and replace that cloudy lens with an artificial lens that restores vision and gets people seeing well again. The surgery is outpatient. It's done under a local anesthetic, but with medicine to make the patient nice and relaxed and comfortable. It's a very quick operation without any pain, and the patients are up and around and functioning. Literally the next day, they're already starting to notice some improvement in the vision. The nice thing about the lens implants that we have is that they can optimize a particular visual distance. So most of the time we correct people for distance vision. They can drive and see very well in the distance without glasses, but oftentimes they need glasses to read with. If they have other problems like astigmatism, which might require correction, there are actually surgical options now that allow us to correct astigmatism as well.
There are secondary benefits as well.
There's very good evidence that suggests that people who have had cataract surgery are at 50% less risk of being at fault in a motor vehicle accident for the first several years after surgery. There's a less likelihood of falling, a substantial decrease in the number of fractures, about a 30% reduction in hip fractures in the first year after cataract surgery. There's evidence that it helps with depression, it helps with overall quality of life, and there's even some beginning evidence now that suggests that people that have had cataract surgery actually live longer. It's a wonderful procedure, and it's a real treat to be able to provide this for people. Every day I realize that there are people who are potentially at risk for losing their jobs, losing their independence. They can't read, they can't do things that they want to do, and to be able to restore that with a very quick operation is a real treat.
For Fox 8, I'm Dr. Mark.
Dr. Mark is sponsored by the Cleveland Clinic.
Okay. That was not the video I wanted to show you. But that was, I did want to talk about cataracts. I just did not want to do that right this second, but I didn't want to stop it midway. So let me, hang on a second. All right, keep that one in mind. Here's the other one I actually wanted to show you about this. This will tell you the difference between open angle and closed angle glaucoma. And this is the one I wanted to show you.
Glaucoma is a group of diseases that are characterized by high pressure in the eye that cause damage to the optic nerve. That damage results in loss of usually peripheral vision first, but if left untreated, it can result in loss of total vision. There are two basic types of glaucoma: open angle glaucoma, which is sort of the garden variety, and angle closure or narrow angle glaucoma, which is a more anatomical problem. It is estimated that over 2 million people in the United States have glaucoma. Unfortunately, over half of those patients don't know they have it. Open-angle glaucoma is treated by a combination of drops, laser therapies, and incisional surgeries. Initially, most patients undergo either a laser or a eye drop. Narrow-angle glaucoma is treated initially with the use of a laser treatment. It is oftentimes followed up by use of medications and eye drops. The only real way to prevent glaucoma is to screen